Now we're going to get a little bit into CTs. And so we'll start with CT abdomen pelvis, my favorite, because it has everything, right? The majority of your organs are all in this area. So there's a lot of pathology that gets tested here. But again, if you have a systematic approach, it's very, very doable. So I want to reassure you that I had no idea what any of this looked like before a year ago, and it's very quick and you can pick it up too. So just to go over basic anatomy to start. So we're looking at this as if I'm looking at the patient and the patient's feet are towards me, right? So the patient is lying flat and I'm standing at their feet. So I'm looking at them that way. So this is the patient's right side of their body and this is the patient's left side of their body, okay? So just to orient you, that's every single CT you will ever see ever. So liver is here, right? Liver is up here. Gallbladder is in the gallbladder fossa immediately inferior to the liver. You see the pancreas, or the pancreas starts sort of like right around here, and the pancreas, unfortunately, you can't see fully on one slice, but the course of the pancreas generally will be like around here down to over here. That'll be the course of the pancreas. Spleen is over here. Then we have both of our kidneys. Adrenals, you can't see super well, but they're not going to test you on adrenal pathology on the USMLEs. That would be super unfair. The aorta, immediately anterior to the vertebral body. I say this to every single student. I say this to every single person. Look what's right in front of the vertebral body, because sometimes the aorta looks crazy and you're like, what is that? And ask yourself, is this immediately in front of the vertebral body? So start with that. Then IVC, slightly to the right. Then we have the duodenum and the bowel, right? So the large bowel, you'll see much more of this gas and more often decompressed, but we'll get through some of that pathology. And then vertebral body, of course.
Yeah.
And we'll go through each of the organs as well. Any other thoughts on that, Blake?
Yeah, just one thing I wanted to mention to just fully emphasize what you're saying. I've seen on past MBME questions or them say to refer to this AAA, for example, an abdominal aortic aneurysm. What findings would you see on CT? And it was calcifications anterior to the vertebral bodies.
So here we're looking at the thorax, the abdomen, and the pelvis. So here, this is the descending aorta, right? So in front of / slightly to the left of the vertebral body, right? So in the thorax, it's a little bit to the left because the heart takes up that whole anterior space. So this is, again, tracking sort of where the aorta is at all of these levels. Next is the IVC, right? So IVC, now we're going to go backwards, right? Because this is blood returning to the heart. So this is low in the pelvis, up in the abdomen, even higher in the abdomen. So again, here we're down at the level of the femorals, right? Right out here, bilateral. Then they come up. Here we have the IVC here again. So this is after they've sort of joined together. And so now we're at the level of the pelvis still, coming up here. And remember, all of the hepatic veins drain into the IVC, right? Portal vein turns into the hepatic vein, comes into the IVC. So this is going to be immediately adjacent to the liver, to the slight right of the vertebral bodies. And then again, here it's almost surrounded by the liver because, as I mentioned, the hepatic veins are all going to drain into it. So you're going to see very close association with the liver. And then as you come up higher, it'll drain into the, obviously the right atrium. And then just solid organs, just to briefly cover everything. This is the heart, right? You can see this nice 4-chamber view of the heart in the thorax. These are the lungs out here. This is the pericardial space surrounding it. If you see a lot of sort of thickening of that space, this is a nice thin pericardial space, but you can see thickening in pericarditis, but you can also see a fluid pericardial effusion. Then here we have the spleen, right? You can see the spleen again. We're looking at the left, right? Left part of the abdomen. Going down, this is that pancreas I was talking about. So this part, you can see the tail much better. This is the tail of the pancreas in very close association with that spleen, coming all the way around, looping here. Here we have the liver, as I mentioned. This liver has a nice, huge hypodense lesion in, which we will just ignore for the time being. But this is the normal appearance, normal location of the liver, I should say. This here, gallbladder. Gallbladder has a couple stones in it, right? You see these large calcified objects here. This one has quite a few stones. Then here, this is actually the adrenal, but ignore it. Again, not a radiologist, don't worry about it. And then the kidneys right here, right? You see these bilateral kidneys. And then the bladder much lower down in the pelvis with all of the urine collected inside of it. So those are the major things that they'll test you on in the adrenal. Here we're looking at the transverse colon because we're up at the level of the liver, right? Much higher up is the transverse. This is the descending colon that will connect with the sigmoid down in this area. And this is the ascending colon, right? And bottom of the ascending colon is where you'll see the appendix. So at the lower level, you'll see the appendix, or I guess the origin of the ascending colon, but bottom in the abdomen. And then the other half of the GI tract, I know it's a lot, guys, bear with me. The esophagus, right? So coming from the top now, we have the esophagus here, turns into the stomach, turns into the small intestine. And small intestinal pathology, they won't really test you too much on because it's impossible to track small bowel in the abdomen. But just to be aware of what you're looking at is all of this sort of stuff is just loops of bowel. So you know. Okay, and with that whirlwind, now we're going to take some cases. Blake.
All right. Yeah, one thing I just wanted to mention on just some of the slides that you just went through.
Oh, of course. Of course.
I just wanted to say that as you were tracking some of those vessels, one thing that you can use kind of, again, as a little trick from a non-radiologist here, is you can kind of use, so when you're tracking the vessels, to see how, it's hard to see actually in this slide because it's purple, but go to the next one. The solid organs. As you can see, if you look kind of at the aorta and the IVC here, you can see that they have a different level of contrast, and that can actually help you to determine between the arterial and the venous system when you're kind of stuck in a pickle as well. I just kind of wanted to highlight that.
Definitely. Oh yeah, absolutely. Nice.
All right. Okay, so let's take us through a case. So patient appears to the ER, and he has chest pain that's tearing to the back.
Nice. A lot of great ones already. Everybody's getting it. Oh my God, these are too easy. We're going to have to make it harder.
Yeah, absolutely. And I like that people are including the Stanford type as well, because that will affect management on those two-step questions. One can be managed with just surgery, or sorry, one has to be, if it involves the ascending aorta, then that must be managed with surgery, as opposed to if it's thoracic only, then that can be managed medically with antihypertensives.
Yep, nice.
And another thing, what does everyone think the main risk factor is here? So
I've got a couple good ones, yeah.
Couple good ones, yeah, absolutely. And it's tough here to really sometimes decide between risk factors because they're all risk factors. But the big thing here actually is hypertension. We are getting hypertension and smoking kind of as our big 1-2s here. Hypertension is our biggest risk factor, and that's at least to my understanding. Is that to yours as well, Sana?
Yeah, absolutely.
Okay.
Perfect. So yeah, great. And so big things here. So for those of you who were not sure, this is an aortic dissection, right? So here we see, again, use my tricks. Immediately in front of the vertebral body, slightly to the left, because we're in the level of the thorax, you see this aorta, and you see this sort of dark line here, sort of tracking along, right? So this is the dissection flap. This should not be here, right? You should just see a nice plain circle with contrast in it. No, nothing else inside of it. This is a dissection flap. And this is type B, again, because it's involving the descending aorta, and we don't see ascending aorta involvement. Having said that, this slice, we can't really see the ascending aorta, so hard to say. But if the ascending aorta was involved, that would be a type A. But here, because we only see the descending, based on this, we can only say type B.
Thanks.
Nice. Awesome. All right, so another case here. So again, please throw it in here what you think it might be. But as I'll sort of take you through what I'm looking at here. So the first thing that catches my eye is this huge structure here with a lot of what looks like contrast material here and this sort of concentric ring of darker material. So just checking my bases, looking around, seeing what else is there. Maybe this is the edge of the liver, hard to say, some bowel, not a whole lot else going on. But again, where am I, right? What am I looking at? So this structure is immediately in front of the vertebral body. And what did I tell you guys that is? What does that have to be? It has to be the aorta, right? And the other things that are helping me to support that is, if you can see here, these sort of like bright spots here, these bright sort of lesions, I guess, on the margins of this sort of ring, these are atherosclerotic calcifications, right? These are all calcifications of the aortic wall. So that's all calcifications. And this here, this sort of dense, darker structure, this is all sort of just this is probably intraluminal thrombus, but this is a huge AAA, right? AAA with a mural thrombus. So the big finding is a AAA, because again, I don't have, the measurements here, but again, greater than 5 definitely needs surgery. Greater than 3 is really the criteria for an aneurysm. But this is, I can assure you, it's greater than 3. And you see this sort of thrombus here as well inside the lumen to suggest that we have thrombosis. And perfect. A lot of people got that too. So again, use those sort of landmarks to figure out what you're looking at, because sometimes it'll be so abnormal looking that you'll be like, I don't even know what I'm dealing with here.
Absolutely.
Perfect.
I think that just is a rule that I always tell students. Trust yourself. I think that, going back to that question that we did together on sarcoid, there's, I think, 7 or 8 different clues that they put in the vignette that you could kind of grab onto. Most students, when I first work with them, aren't familiar with the fact that, 10.8 is hypercalcemic, which is very reasonable, especially without knowing the reference ranges as you begin to learn. And so, it's okay that you don't know that point. I want students to focus on the things they do know, not the things they don't know. And, when you see a CT that you're not familiar with, I think it's easy to panic. But I think the thing you want to do when you feel that panic strike is, stick to what you know. Say, okay, I'm going to look here. Where am I? Okay, I'm in the abdomen. All right, if I'm in the abdomen, where's the aorta? Oh, this is the aorta.
Absolutely.
All right.
Definitely.
All right. So our next case, I'm in the abdomen again. Okay.
Oh yeah.
All right. And so my feet again are coming towards me. So the left side of the screen is the right of the image. And again, I'm looking here at my vertebral bodies, and those are going to be the most white, so kind of the most radio dense part here. And so that's going to be significant for, a hard thing like a bone. And just interior of that, I see my aorta. It looks like I have some kind of aortic calcifications. My apologies, said my aorta on the and then my IVC would that be maybe an IVC filter then?
Perfect.
Yeah.
Nice.
So and so as we go through here, I apologize. Why? Yeah, that's what I was looking at behind. What are we looking at here behind this?
Yeah, perfect. So yeah, a lot of people are thinking about the exact same thing. So this is a tricky one for a couple of reasons. So exactly like Blake said, and this is why we put this case in, right? Because now we're testing you a little bit further. So immediately in front of the vertebral body, let's start with that, right? So we have these 2 vessels, one with slightly more contrast, one with no contrast, and these sort of very bright structures on the periphery. So what I'll start by saying is, we know we have 2 vessels. We know the aorta is always on the left, right? I mean, barring some anatomic variant, we know the aorta is on the left. But what I'll also say is these little spots here are very, very equally spaced out, right? Calcifications are not like that. I'll go back to the prior case. These calcifications is a little bit here, a little bit here, a little bit here, but it's not very uniform. This is very these are this many centimeters, this many centimeters. We're seeing a very structured thing. So the first hint to me that this is the IVC is the fact that it's to the right. Second hint is that, okay, this looks like a foreign object rather than calcifications because of how uniform that is. And so again, if you just use those things alone, that makes you think, okay, IVC filter. And then a bunch of people were asking about this vertebral body, like, why does it appear this way? And so my best answer is, I think we're just catching it at an off level, right? I think we're catching it in between slices here. In general, it's very, very hard to analyze vertebral bodies if you're not looking at quote unquote bone windows. And what that means is you're looking at a specific narrow range of like Hounsfield units, which again, you don't need to know the details, but basically it helps you see the bones better because of the way you calibrate the image settings. And we'll have a picture later on in bone windows, so you'll get a better sense. But at this point, hard to say anything about that. That looks normal. But the big thing here is this IVC filter.
Absolutely. And I think the important thing is, when you see this CT and you say, oh, okay, oh, shoot, I'm scared. Yeah. What am I going to do? I think you just realize, what do I do now? Okay, I know that I'm in the abdomen. I looked forward and I thought, when the first time I look at this, I think, okay, maybe that is the aorta. And then I say, wait a second, there's two vessels. I remember my trick as a non-radiologist, that the darker thing's probably going to be the vein. And then, as you say, I have these evenly spaced things. And if that didn't click the first time, which is possible and very possible, then I'll glance quickly. I'll go to the vignette. I'll trust myself going to the vignette, and then I'll probably think that this person maybe has blood clots and a reason that they can't be anticoagulated because they may be bleeding. And then I'd say, oh, well, the treatment for that would be an IVC. And then I look here and I confirm that. So you don't have to be a radiologist to get these questions right.
Absolutely.
Sorry.
Absolutely. No, definitely not. Definitely not. Awesome. Okay, so here is my bone windows that I was just speaking of. So here, just to briefly talk about the bone windows while people take a look at this and see if you see anything weird, please feel free to throw your answers in. But as I'm waiting for people to do that, I'll just say, here you can see, I cannot make out the liver here. This is, I guess, what the liver is, but you can tell that the window and leveling, the sort of like difference in the color scale here is so impossible to sort of discern subtleties here. So very, very difficult to discern what's going on here. However, the bone, I'll say, I can make that out a lot better, right? I can see a very clear sclerotic rim. I can see the sort of cortex here. The ribs are also much easier to determine. If we had any sort of like bony lytic, prostatic, or lytic blastic lesions, much easier seen on these windows where you see this wider range in the bone and a very, very limited visibility of the others. And these are just tricks that we use in radiology to better see certain areas, because the human eye cannot see the same number of levels that the computer can. So with that, we're having a couple of people are putting in what they're seeing here. Great. I'll give you a hint. It is, again, the vessel immediately interior to the vertebral body that I'm looking at. So here, I'm looking at the vertebral body, right? And so this here is the only thing that's really jumping out at me, right? I'm not seeing a clear additional anything else. So we're seeing a circular structure immediately in front, a touch to the left, right? Not really surrounded by the liver. So this has to be the aorta, right? Always the aorta. But a lot of people might think, and I've gotten this question several times, is this just a contrast-filled aorta? And what I'll say is, all this whiteness is actually calcification. And the reason that I know that, twofold. One is that it sort of matches this sort of periphery, the structure, the bone structure, right? It's a very similar Hounsfield unit to the bones. And also, it's very irregular. If you look at the contrast in the aorta here, this is like a smooth, it's all homogeneous, it looks the same throughout. Here you see, there's like a little spot here, a little spot here. The periphery is a bit brighter. Inside, it's not quite as bright. So this sort of irregularity gives you that same thing of, is this a man-made thing or is this the body doing its thing, right? Same idea with contrast. Contrast is man-made, so it's nice and uniform. The whole idea of this IVC, man-made, nice and uniform. The human body is just depositing calcium wherever the heck it wants. So that is going to give you the hint of, does this look like a very uniform structure or something abnormal? So this is aortic calcification, so severe atherosclerotic calcification. And then we have the different views here. So this is the sagittal reconstruction of the same patient. And you can again see just extensive calcium throughout the aorta. And this, we're probably getting this slice here where it looks to be the worst. And this is just a 3D reconstruction of the same thing. You can see all the bones are very clearly seen. And with the bones, you can see all of this calcium in the aorta. It's just very significant stenotic disease.
Oof.
All right.
Yeah,
not good. No bueno.
Second vertebrae there.
Oh, I know, seriously.
All right. Okay. So again, I think the first thing you got to do is you got to orient yourself. Okay. So I have my patient's legs coming down at me. It looks like I'm seeing two bony processes over here on the side. This would be consistent with probably the pelvis here. So I'm in the kind of my lower abdomen. So, all right. So that helps me just kind of think initially about my differential, even immediately. If nothing was jumping out at me, I went to my vignette. And so as we kind of go to the center, we see this kind of this area that's kind of soft tissue density, but also has these pockets of air. And how do I know that they're air? Is that they are completely black, so completely radiolucent. And so I also see aside next to those kind of these kind of areas that are more radiodense. And so what do we think is the possible diagnosis here, everyone? What other things would you pick up here? What other things would you pick up here as well as the more kind of fine-tuned radiologist?
Yeah, absolutely. So I think the big thing, the nice thing about being lower in the pelvis is there actually isn't that much to look at. So here, what we're looking at here, so again, we have sort of the iliac bones here, right? Both iliac bones. This is probably the rectum, and it probably loops around with this here. So here, what we're looking at is actually the sigmoid colon, right? And so all of this other stuff, we're just looking at small bowel, small bowel, small bowel, small bowel. And so here, when I'm looking at the sigmoid colon, there are a few things. So I'm looking at sort of the expected contour, right? Should just be a simple tube, right? Nothing else, simple tube. But we're seeing all of these outpouchings. And so exactly as Blake described, and as a lot of you have nailed already, we're looking at diverticula, right? So lots and lots of diverticula. And otherwise, not a whole lot else going on. But the key thing is figure out, am I in the pelvis or am I higher up in the abdomen? A few people mentioned the pancreas as a possible because it has that similar sort of curved shape. And I can see that sort of curved shape throwing people off. Couple of reasons why that's not the case. A, you can see we're in the pelvis, right? The pancreas is up here. Pancreas is up by like your sternum, you know, high up in the abdomen. So we're in the pelvis. I know this because of the bones. And then B, the pancreas does not have gas in it. Unless you have like severe, you know, complicated pancreatitis, pancreas will not have all these locules of gas. So again, use your landmarks to sort of figure out where we're at. So with that, yeah, Blake.
Yeah. So with that, I mean, diverticulosis, this is our answer. But I think that there's some other potentials here. So how are we going to determine between, you know, a diverticulosis or a diverticulitis? And that kind of leads us into things that you'd look for maybe that aren't in the radiographic image. And you can certainly find these things sometimes there, but I know that, you know, if I was thinking about the differences between diverticulosis and itis, I would certainly be looking at my vignette, some of my objective findings. They'll never lead me astray. A patient's temperature will always be their temperature. And fortunately on the test, what I tell my students is this isn't the real world where we have plenty of gray area and, you know, sometimes we can't explain things. This is the test. Everything's deliberate. It's black and white. If someone has fever, they have a fever. So always check your answers and make sure that your objective information backs up the answer that you're selecting.
Definitely.
But let's get into some of these features. Okay. So when we're looking at the features of diverticulosis versus itis, they're both going to have these diverticula that Sana was mentioning, these outpouchings of air. The thing that we're looking for that's a little bit different is, you know, fortunately we have the positive arrow sign here which is always helpful in radiology. But we have the fat stranding here, as well as the bowel wall thickening. Those are unique to diverticulitis as opposed to diverticulosis. However, while Sana will be able to tell us a little bit more about the image here in a moment, I would say the biggest things that I would look for to help me discern this would be the patient's temperature, some of those physical exam things that will help you as well. Sana,
yeah, definitely. Yeah, and the thing that's most useful to me, and this is like a generic thing that I used more before I was a radiologist, but still use very much now, is does it look like a mess, right? So here, when I'm looking back at this image initially, I can very clearly trace the outline of the bowel, and I can trace the outline of every single diverticulum, right? It's very obvious to me where it ends and where it continues and where the mesenteric fat is. And so this, to me, is just plain old diverticulosis. There is no inflammation because there's no sort of hazy messiness around it. So that tells me that. This one, you can see, I have no idea what's going on here, right? So I know that this person has diverticula because you see a bunch of focal outpouchings outside of that normal tubular lumen that we were describing. But here, the bowel is thick appearing. We see all of this hazy sort of whiteness around it in the fat. We see this, again, this sort of very unclear pattern of like, is this wall thickened and this wall here? So that sort of messiness is how I'll best describe it for non-radiologic purposes. That makes me think more of diverticulitis, and really more than that, makes you think of inflammation. If you see this sort of messiness around the kidney, you think of pyelonephritis. If you see this sort of around the gallbladder, you think of cholecystitis. Like all of that sort of fat stranding is your big hint in terms of any inflammatory process.
Thank you. That's great. Okay.
Perfect.
Looking at some children.
All right, we got a tough one. We got a little baby here. So transitioning to KUBs a little bit. So what are we looking at? So I can tell you right now, we're looking at a baby. And I'm looking at their belly. And what do you guys think? What am I looking at? So as you put in your answers, I'll sort of keep going on. And then we have a little bit of gas here. And then when I'm looking at sort of a diffuse bowel gas pattern, right? I'm just seeing a lot of gas in the belly. And that to me is concerning because I should be able to see, if I see colon, that's fine. If I see large bowel, that's okay. But this sort of crossing back and forth, the only thing that goes back and forth like that is small bowel, right? So that suggests to me that I'm looking at some small bowel with a lot of gas in it. 1 or 2 loops is okay. This is much more than that. What really is concerning to me is the fact that I see this very clear outline here. I can very distinctly trace the wall of the small bowel here. And also here, I can trace the wall. And so remember, on CT, black is air, right? And same thing goes here. Black is air. So what I'm looking at is air inside of the wall of the small bowel. And that has a very specific name in radiology. So does anyone know what that name is called? A couple of people have already put it out there. What is it called when you have air in the wall of the small bowel? Perfect. Awesome. A lot of people are getting it. Yeah. So this is pneumatosis, right? Pneumatosis intestinalis. So pneumo, air, tosis, I don't know what that means, inside probably. Intestinalis, right? Inside the intestine. So you have air in the wall of the intestine. And so that in children is very specific for necrotizing enterocolitis, because you have all of this air often seen in preemie babies because they have this bacterial infection that's basically eating their bowel up.
Absolutely. And again, I think the biggest thing here for a non-radiologist, again, is that I'm going to recognize that I think this preterm baby has abdominal pain inside consistent with necrotizing enterocolitis. And then I'm going to go back to the image and see this. I probably will honestly not see this the first time, and that's okay. So don't kind of turn your wheels spending precious time looking at an image that you may figure out kind of after looking at the vignette.
Absolutely.
Yeah.
Absolutely. Awesome.
Yeah. Thank you. All right. All right. So we're back in the abdomen. And so looking at the abdomen here, we have a patient who's presenting, and we're looking at their liver, and we're seeing not this consistent appearance of a liver that we normally see. We're seeing these kind of these hypodensities that are kind of nodular in appearance, I would call them. And so this is concerning multiple nodules within the liver. And so what are some of the things that we think of when we think about nodules in the liver? It would certainly matter kind of our differential based on kind of, again, the patient that we're looking at, the demographics, things like that. Is this patient on OCPs, things of that sort?
People are nailing it. We got a lot of different ones here. So I'll just read out some of the answers we have here. We've got a lot of mets all over the place. We have a echinococcus, great thoughts. We have a lot of infectious processes, great thought too. More mets. Okay, yeah. Good.
Yeah, absolutely. And I think this is a good kind of other question. What's the most common cancer you see in the liver? And that's usually not a primary tumor. Yeah. Nice.
Got a bunch of them. Good. Yeah. So primary, a lot of people are saying colon, which is correct, right? Rectal cancer, colon cancer. And the reason for that is the portal venous system drains those organs, right? Or those viscoses. So the portal venous system is draining those, getting all those cancer cells directly into the liver before it goes to anything else. So mets are going to go right there. Excellent. Very good.
Absolutely. And kind of thinking about some of these other diagnoses, echinococcus, things like that, those would have some different findings. You'd expect kind of a shell, an eggshell calcifications for your echinococcus. We just expect central scarring for, is it fibronodular hyperplasia, is that right? All right.
Focal nodular.
Focal nodular. Sorry.
Perfect. Awesome. Yeah, and the big thing I'll add here is, again, just to reiterate, not going to beat a dead horse, but again, the history is going to tell you this, right? The history is going to tell you, oh, patient, 80 years old, hasn't had a colonoscopy ever, coming in with weight loss and rectal bleeding, get a CT, and this is what you find, right? That's going to be the history. It's going to be a slam dunk. Awesome. All right. Now we have another one. So this is a little bit trickier, a little more subtle. So what I want to take the opportunity to do here is go through some of the organ systems, right? So go through one by one. So here I'm looking at liver, right? So the right side of the body, looking at the liver. As I move across, I'm looking at the kidney here, immediately in front of the aorta, immediately in front of the vertebral body, so the aorta, right? IVC, looking at the stomach here, looking at the spleen here. It looks a little bit big on this slice, but might just be normal. And so the real question is, any of these things look abnormal to you? Anything jumping out on these images here? Good. All right, so we have one person who's gotten it so far. Anybody else? Okay, good. 2, up to 2, 3. Okay, people are getting it now.
All right.
Very good. So
good.
Big thing here that I'm looking at is this sort of irregular hypodense lesion in the spleen, right? This is not the same color. This is not the same sort of shade of gray, rather, as the rest of the spleen. And so what I'll submit to you, and you can sort of tell me if you can believe this, is that this is almost a wedge-shaped portion of the spleen, right? You can almost see a little triangular component to this hypodense lesion. And so that suggests to me always infarct, right? If you see a clearly demarcated wedge-shaped hypodensity in the liver, in the spleen, in the lung, in the kidney, anywhere, that is an infarct. So this is likely due to some sort of embolic or thrombotic process. Who knows? We would have to look at the history, but this is absolutely a splenic infarct. Very good. People nailed that one.
All right. So taking us back to the abdomen, we always want to use our landmarks. So feet coming down on us, and I know I'm repeating myself a little bit here, but you know what I always say to my students is perfect practice makes perfect. I always want to kind of think about the right things every question, because then I don't miss things. Okay, so as I'm looking here, I want you to look across and see, you know, does anything appear abnormal? Okay. So I want to look around and see our vertebral bodies, our kidneys, kind of a little bit of the liver we can see here. Thank you so much for guiding the cursor.
Of course.
And then as we move across the abdomen, we see a couple loops of bowel here with air, and then we're moving through. And what's this perfectly circular thing? I think that's always something that jumps out at you when you see something perfectly circular. And I'm thinking, oh, is that a blood vessel? You know, being perfectly transected? No, that's not where my aorta or IVC it should be, and it's a little bit bigger than that. So that makes me think if it's kind of circular on 2D, that it may be a sphere, and so that kind of makes me think about things that would be spherical. So what are people thinking here?
We got one person with the right answer already. Nailed it. What else? Anybody else got any thoughts? What do you guys think? Oh, boom, boom, boom. There we go. A couple more.
Yeah. So I think the important part here, you know, I think that one person wrote cyst versus pseudocyst. I think, you know, playing your odds here, this is going to be a pseudocyst, if nothing else. I'm not sure. I'm sure there's a radiologic finding that you can look at here as well, but pseudocyst is much more common than the pancreatic cyst.
Yeah, absolutely. In the pancreas in general, this person will likely have a history, again, going back to the history, will likely have a history of recurrent pancreatitis, right? They'll have come in multiple times for epigastric pain, probably have some risk factors, maybe alcohol gallstones are the classic two. And then they have this. You don't really get cysts in the pancreas. You don't ever actually see just simple cysts in the pancreas. What you'll see is a pseudocyst as a complication, and you'll see sort of other precancerous lesions, but those are much more suspicious looking than this. So this is, again, classic pancreatic pseudocyst inside and you can almost actually imagine here, you see this sort of like lining. This is all pancreatic tissue. So it's a little bit subtle, and it's kind of hard to see if you're not a radiologist, but you can see this sort of very subtle sort of pancreatic tissue surrounding as well.
Thank you.
All right. Awesome.
All right. So again, looking at this image, we have our feet coming down at us. So this person may came in, I'm not sure if it's a male or a female, but coming in with recurrent UTIs, and now maybe some flank pain. Okay, and so as I kind of come here, I look at my vertebral bodies. I'm going to my right side, and so I look at my right kidney, and well, it looks a little bit different than normal. And then I look over to my left kidney, again, that also looks more abnormal. I can see kind of, especially on my left kidney, I can see a little bit more of my kind of normal renal calyce. But then within that renal calyce, I see this kind of this less dense, this kind of gray area, this kind of darker gray area that's kind of homogeneous. So that's telling me that there's probably some type of fluid in there. And so kind of these kind of homogeneous kind of fluid-filled structures kind of within the kidney. So let's see kind of what we're kind of thinking here. Oh, we got a couple people with the right answer. Great.
Nice.
Yeah, so this is hydronephrosis. So this one's a tough one, I think, to pick out, but you know, if you stick to the process here, kind of orient yourself within the abdomen, kind of look at every structure that you normally see. I think you'd look at the kidneys here and say, what, those look a lot different than normal.
Nice. Awesome.
Anything else you'd add here, Sana?
No, I think you nailed it. I mean, the big thing is really just, a lot of this is just knowing what normal looks like, and just seeing a lot of them over and over again. And now by this point, we've seen a couple of kidneys, and I just urge you to sort of look every time, even if the priority is not the kidney, if it's a clear pancreatic pseudocyst, right? Look at the kidneys just to get a sense of like, this is what a normal kidney looks like. And that way, when you see this, you'll know, okay, this is not a normal kidney.
Yeah, absolutely. And behind the vertebrae, that's the paravertebral spinal muscles.
Nice. Awesome. All right. And now just very briefly, I'll talk about the different views. So almost all the images that you'll get on the exam will be axial images, right? So cut, slice, straight across. But sometimes they'll give you the coronal view. So this is looking at the patient face on. And same thing here, the appearance. Liver's on the right, spleen is on the left, stomach up here, pancreas sort of loops like a little S thing here, gallbladder's in this fossa, all the small bowel, bladder, and then the colon you'll see on the peripheries, right? So again, you'll see ascending, transverse, and descending colon there. But they could give you these slices. Typically, they'll give you the axial.
Yeah, and I would say if they are going to give you these kind of these different slices, they're going to test you on the most common things, bread and butter stuff often.
Yep.
So free air into the diaphragm, things like that, that you kind of that would translate to some degree.
Yep.